Once again, good evening and a very warm welcome to our webinar on wrist and hand treatments. My name is Louise, I'm your host for this evening. I'm delighted to be joined by our expert speaker, Mr. Andrew Smith, consultant orthopaedic surgeon here at Benton Hospital. Tonight's session will begin with a presentation from Mr. Smith, followed by a live Q&A session. If you have any questions at any point, please feel free to submit them using the Q&A icon at the bottom of your screen. You're welcome to ask these questions anonymously or include your name. Just a quick note that this session is being recorded, so any names shared may be visible in the recording. To help us get through as many questions as possible, please do keep them brief. If you're interested in booking a consultation, we'll share the relevant contact details at the end of the session. I'll now hand over to Mr. Smith to present.
Hi, good evening. Thanks for joining me. My name is Andrew Smith. I'm a hand surgeon. I've been working in East Kent for nearly 20 years. I've been working at Bellenden for the last 5 years or so. I've always had an interest in hand surgery. I think it's absolutely fascinating, and it's one of the parts of the body we really can't do without when interacting with the world. And any problems with the hand cause significant dysfunction. My particular areas of interest are joint replacement in the hand and wrist, as well as the more common problems. I did my fellowship training in America, which was a fascinating place to do such a thing. I'm going to spend most of this presentation talking about the more common problems in the hand, so arthritis at the base of the thumb, Dupuytren's disease, peripheral nerve compression, trigger finger, trigger thumb, and ganglions. There's plenty of other things that present in the hand, and I'm very happy to answer questions around the less common bits and pieces that I could take care of as well. So we'll start with osteoarthritis at the base of the thumb. This is a really, really common problem. It predominantly affects females over the age of about 55. And if you x-ray that group of people, between 20 and 30% of them will have changes of arthritis on x-ray, and probably half of those will be symptomatic. So it is a really common problem. Osteoarthritis is where the bearing surface wears, and that then produces can produce quite significant pain. Not all of the treatments that I'm going to discuss revolve around surgery. You can try splinting, medication, and pain relief, as you can with any osteoarthritic joint. Steroid injections have a place, and so does specific physiotherapy to look after the thumb base. The most widely offered surgery in the UK is trapeziectomy, and that's where the small bone at the base of the thumb is removed. This then, by default, removes the arthritic joint. The body then forms a new scar tissue false joint over time, and this works well for relieving pain. Probably 85 to 90% of people think this is a good operation, but because the joint isn't as mechanically well reconstructed as it could be, for example, with some of the bigger joints like a hip replacement or a knee replacement, some people find they have a weak grip and their recovery is a lot longer. And I'll talk about my preferred option in a moment, but briefly mentioned on this slide is joint fusion, which certainly in very young people with post-traumatic arthritis can be a really good option, but it does by default remove the movement of the joint. So my preferred option is to replace the joint at the base of the thumb. This is done, hopefully you can see there, with an implant, which looks like a tiny hip replacement. It's a ball and socket joint. This preserves the length of the thumb. And by default, the joint is reconstructed. So grip strength and pinch strength tend to be good. And one of the really good advantages of this treatment over a trapeziectomy procedure, for example, is that the recovery is within 3 or 4 weeks in the majority of people. With a trapeziectomy, the recovery is usually 3 or 4 months or sometimes longer. It's done as a day case. It can be done under a short general anaesthetic. You go home the same day, and you will need some rehabilitation afterwards. But because it reconstructs the joint, the actual level of input from the physiotherapy team is less than it would be for a trapeziectomy. Some people use plaster. I have to say I've moved away from that and don't any longer use plaster to support the thumb, just a big bulky soft dressing which comes off after about 10 days or so. And you can use the hand straight away. Anything heavier should probably wait about 6 weeks or so, but you can use the hand straight away. This is the standard of care in continental Europe, where my colleagues there have been carrying out joint replacement for the thumb-base arthritis for probably 20 years and have really got through most of the learning issues with how to use this implant. Slightly different, but very common problem is Dupuytren's disease. This is a condition where the body makes a hard fibrous tissue that gets deposited in the hand predominantly, that can affect other areas. This causes lumps, bumps, and these progress into cords or almost like strands of fibrous tissue, which slowly pull the finger over. Itself, it's harmless, but you can imagine if you can't open your hand fully, this can significantly impact on how you use your hand. The cause is largely genetic. It runs very, very strongly in families. In the Scottish population, some time ago, is referred to as the curse of the Macrinans, because those guys couldn't play their bagpipes because their fingers were so curled in. Random silly fact. So that's the predominant cause of it, is your genetics. So you can't change your parents. But there is an interaction with alcohol, some of the old-fashioned anti-epileptic medications. People that have diabetes tend to get worse disease as well. So when it's not causing a contracture, it's best left alone because you cannot cure it. You can, however, treat it. The least invasive way of treating Dupuytren's contracture, if the cord is very thin and predominantly in the palm, like in this example, that cord can be divided using a needle under local anesthetic. And that doesn't remove the bulk of the tissue from the hand, but does allow the finger to come to a much better position. And this is a very easy, quick way of getting a better improvement in your finger position. If the finger is contracted further up towards the proximal joint and the cord is thicker, then the needle procedure is much less reliable. This is an example of what's called a fasciectomy, where that hard fibrous tissue is removed from the hand to allow the finger to come straight. And in relatively rare cases, it may be that the finger's so contracted you can't actually sew the skin back together in a meaningful fashion, and you need to replace it. And that's an example of that in the bottom picture there. This is referred to as a dermofasciectomy. And you can see an outline there with somebody planning to do that. That's less common and is not performed that widely. But if your disease is severe or it's come back and come back again, then this may be the answer for getting a better position. But the majority of patients with thick, heavy disease, just excising it from the hand gives a good result. This again is done as a day case, typically under a short general anesthetic. You will need quite a lot of hand physiotherapy afterwards to get the hand limbered up, but the majority of people get a really good result from this surgery if the patient hasn't waited too late. Severe contractures are more difficult to treat. We then move on to peripheral nerve compression. There are two of the most commonly compressed nerves in the upper limb, the ulnar nerve, which is cubital tunnel syndrome, and the other most commonly compressed nerve in the upper limb is the big median nerve as it comes through the carpal tunnel. And we'll go on to that in a moment. The ulnar nerve comes from all the way up from the neck down to the small finger. It provides the sensation in the small and ring fingers. And it also supplies the muscles in the hand. So compression of that nerve will result in numbness and pins and needles that can be quite dense in the small and ring finger. And if it's left and that compression gets worse, the hand can get quite weak and positioning of the fingers can become increasingly difficult. And if it's left a lot for a long period of time, you can get a deformity referred to as an ulnar claw hand. Most people, however, seek treatment well before that happens. It's best treated in the majority of cases surgically. This is done again under a short general anesthetic, and there's a small cut made just on the inside of the elbow where you can see that highlighted with a little arrow that says cubital tunnel. That's the area where the nerve gets compressed. And if you've ever hit your funny bone, it's not really a bone you're hitting, it's the ulnar nerve where it runs through that tunnel, and it's very superficial. Most people recover from this usually pretty well, but the total recovery in terms of sensation completely returning to the tip of the finger can take really some time, and it's usually gradual because the nerve has to regenerate if it's severely squashed from the elbow all the way to the tip of the finger. But in terms of arm function, that's pretty much straight away. Carpal tunnel is the most common compression neuropathy in the upper limb. It probably affects about 1% of the population, and is something that any hand surgeon does an awful lot of. It's really, really common, and the symptoms can be really very disabling. The early symptoms are just a little bit of numbness and pins and needles intermittently, are often ignored, and not unreasonably so. But at the other end of the spectrum, patients can present with severe pain at night that stops them from sleeping, and that can be really troublesome. Again, if no treatment is sought, ultimately the fingers can end up almost completely numb, so that picking up small objects can be difficult, and the hand use again becomes really quite compromised. Carpal tunnel syndrome is predominantly a clinical diagnosis, although if there's any doubt, neurophysiology testing, so proper formal nerve testing, can be carried out. That's available here at Benenden, and that can help in some cases, but a lot of people, it's pretty obvious what the problem is. And if the symptoms are comparatively minor, steroid injection close to the nerve is really useful, and for a lot of people that will allow the situation to settle. But if symptoms are more severe, more constant, then a carpal tunnel release is a good operation in terms of it works well, it's easy, it's quick, and the rate of complication from carpal tunnel release is really very small. It's done under local anesthetic, takes probably between 10 and 15 minutes, and you go home pretty much as soon as it's finished. Now, you can use the hand. It's important to use the hand to keep it nice and mobile. That doesn't mean you can go and dig the garden up or go to the gym the following day. But using it around the house, light everyday activity, is completely fine, and I would fully encourage people to do that so the hand doesn't stiffen up. And as I said, it's a good operation that works well. Trigger finger or trigger thumb is another really very common presentation in the hand. For reasons we don't completely understand, the tendons that bend the fingers down or bend the thumb down can develop nodules, and these nodules mechanically lock or stick in the fibrous sheath that runs in the digit, and you can see that on the presentation here, just there. Why this happens, we don't really know, but it's more common again in diabetic patients, and that's usually if there's a cause, it's diabetes. The diabetic patients tend to have this worse than non-diabetic patients, and it can be a real nuisance. It can be inconvenient, just having your fingers stick in the palm of your hand and you manually unlocking it. It can be quite dangerous if your finger sticks and catches around steering wheel of a car or the handle on a kettle. And it can be a real problem if that movement is permanent, because sometimes a small number of people would present with their finger locked into the palm of their hand. If that happens, it's one of those things that ideally is dealt with really very quickly, because if it isn't, the joint can be permanently stiff even after a trigger finger release. That's unusual, and the overwhelming majority of people can be treated with a steroid injection. This is a very easily administered, quick injection that can be done in clinic without any particular special preparation or need to rest the hand, particularly afterwards. You can drive home after it, for example, but equally I wouldn't suggest, again, a heavy workout in the gym or anything like that afterwards. But again, the following day, you should be able to use the hand pretty much normally. And the steroid injection will get most people's symptoms to settle within 2 weeks. If you're unlucky, and probably 10% of people or so are unlucky after a trigger finger or trigger thumb injection, then the option is there for a trigger finger, trigger thumb release. Again, this is not dissimilar to the process involved in a carpal tunnel release. It's a local anesthetic operation that takes about 10 minutes, and it's overwhelmingly successful. It's pretty straightforward. The chance of complication and problem from this surgery is really very small, and most people make a great recovery. Their sutures dissolve, and their hand function returns to normal in a couple of weeks. That's just an example of some exercises that can help, and that's just a mention of the steroid, which I think it probably is slightly higher than that. Probably 80 to 90% of people have their symptoms resolved. Moving on, ganglions are the most common lump in the hand and wrist. They are a pressurized collection of fluid. When you operate on them, it's almost like a sort of wallpaper paste or gel. And it looks like a little balloon with the neck of it attached to the joint where the fluid comes from. And then it's much bigger above, as you can see in that person that's got a wrist ganglion, which is probably the most common lump position for ganglions. They're completely harmless in themselves. For some people, they're a cosmetic issue. For a smaller percentage of people, they can be quite uncomfortable. If they're on the front of the hand, across here, where you would grip, they can be really quite uncomfortable and a nuisance for people that use their hands for heavier manual work or play tennis or golf. It feels like they're gripping onto a little pea. And these are often called a pearl or pea ganglion in the palm of the hand. Exactly why they happen, we're not really sure, but they are very common and comparatively easy to treat. They can be aspirated, and some people would advocate this. This has a relatively limited success rate, and it's not my personal favorite choice of treatment for these, although if a patient really wants an attempt at aspiration, I'm very happy to do it. But the lowest rate of recurrence is to surgically remove the ganglions. Now, depending on exactly where they are, it depends whether you need a tourniquet, whether it's done under local anesthetic, which the majority of them are, or whether you should use a general anesthetic and a tourniquet to just see exactly where the ganglion is and if it's close to one of the arteries or some other key structure to ensure that you don't damage that. But the majority aren't. The majority are easily dealt with under local anesthetic, and they're easily removed. It's a comparatively minor operation. The biggest risk of the procedure is the ganglions come back, and they do in 15 to 20% of cases. But if you're an optimist, there's an 85% chance you're going to be fine. And that stops them from coming back. It removes them, and the hand heals up pretty quickly. It's one of the good things about operating on the hand. It has a great blood supply, which generally speaking means it heals really well. And those are the main bits that I was going to talk about, really. Sorry if I rattled through that a little bit, but I'm very happy to take questions and talk about those particular problems, or indeed anything else that people want to ask.
Great. Thank you, Mr. Smith. So let's move into our Q&A session. Really pleased to have lots of questions already. So that's great. And if you do have them and you haven't asked them yet, please do. Like we said, just try and keep them brief so we can get through as many as possible. So our first question from Maureen, she's had explain if I can't, sorry if I can't say it properly, Dupuytren's contracture for over 30 years. She's had one successful operation on her right hand, and she's had 2 operations on her left hand, both from different surgeons and both unsuccessful. Can she have a 3rd operation, or is there an alternative? She also has spasms and cramps in both hands for the past 3 years. Is this connected?
So I'll take the last part of that. It can be connected, but that's largely because the fingers aren't in a normal position. So you're trying to use your hand in an abnormal fashion, which can put additional stresses and strains on the small muscles in the hand. So they can be connected, although they're not absolutely definitively. With regard to the Dupuytren's disease, the biggest problem with Dupuytren's disease is it recurs. So to say that it's unsuccessful might mean that the finger was never ever straightened to start with, or that the contracture has come back, which are slightly different endpoints to the finger being bent. If the finger was never straightened to start with, I wouldn't have thought a further attempt would help. That doesn't seem likely, because it sounds like the joint would be sort of intrinsically stiff and solid. If, however, the finger has been made straight and it's just recurred, then you can have as many operations to straighten the finger as is necessary. Each time it does become more difficult. The results are probably less good. and the chance, as I say, the chance of complication goes up. But certainly if a finger's recontracted, it definitely can be re-straightened. And that's that situation where I talked about a dermofasciectomy, where a skin graft is used, maybe a sensible alternative in that situation. But you certainly can have as many operations as you need to get your fingers straight if the finger is in a position where it's functionally a problem.
Right, thank you. Raymond asks, what determines the operation on the back of a palm for carpal tunnel? How long does it take to recover from carpal tunnel? And what degree of functionality is expected to be achieved after a carpal tunnel?
So the carpal tunnel is on the palm side of the hand. So that's where the incision goes for carpal tunnel release. Can they see that? Can I go back?
Yes.
Okay, I'm just going to go back through the slides. Just so you can see where it is. Well, there we go. So that's supposed to be looking down on the front of the hand with the fingernails on the back. And where the big yellow nerve is, the incision is made as you're looking at it, just to the left of where the yellow nerve is. It's about 3 centimeters long, just at the heel of the hand. Recovery in terms of just everyday hand use is pretty much straight away. So you could help yourself get undressed, dressed, make a cup of tea the same day. Going back to heavier work, probably 3 weeks, maybe 4 weeks, something along those lines. The degree of functional recovery you should get, as long as the nerve is not irreversibly compressed and therefore damaged, you should return to pretty much normal function. There's a small number of people where the nerve is severely compressed and has been for a prolonged period of time, that the recovery is more difficult to predict. And as one gets older, nerve recovery is also slower and less likely to be complete. But if somebody's nerve is not particularly compressed, they should make a full recovery.
Thank you. Malcolm asks, is there a connection between osteoarthritis and Dupuytren's in the hand?
So there's a short version of that, no.
Okay.
They're both extremely common.
Okay.
It's quite common for hand surgery patients that come and see me that they have more than one thing wrong with their hand. They may have carpal tunnel. They may have Dupuytren's disease. And if you're much over 55, you're very likely to have 1 or 2 arthritic joints, even if they're not particularly symptomatic. So they're not caused by each other, but they are, what's the word? They're very commonly seen in the same patient.
Thank you. Okay. Marina says she's had carpal tunnel syndrome diagnosed about 9 years ago with limited symptoms, occasional pins and needles, and numbness first thing in the morning. She's reluctant to have an operation, has not heard of steroid injection as an option. Could you expand on that?
Yeah, so steroid injections, in my view, are useful for treating carpal tunnel syndrome, and there's 2 uses for them. One is if you're not sure if the patient's symptoms are carpal tunnel syndrome, if you place a steroid injection close to the nerve, if they have carpal tunnel syndrome, because not everybody has absolutely classic symptoms, but if that patient has carpal tunnel syndrome, they will get better, even if it's for a relatively short period. So they can be used in diagnostic terms. For treatment purposes, they are extremely useful, again, for people with relatively minor symptoms, I guess a bit like Marina, and they can relieve those symptoms completely. If you use neurophysiology to try and help plan who should have a steroid injection, there's a scoring system that was developed in Canterbury, which scores patients from 0 to 6, depending on how badly functioning their nerve is. And certainly patients with a grade 1 or 2 carpal tunnel syndrome will usually derive significant lasting benefit from a steroid injection. And that would be my preferred treatment option with people with minor symptoms.
Thank you. Gwen says, been hearing a lot about CMC joint replacement horror stories. What is the success rate of the operation and what are the complications?
So I'm surprised to heard horror stories. I think it's one of the biggest advances, certainly in the last 5 years, within hand surgery. Historically, some of the older implants didn't function that well. And I suppose the French population put up with a lot of that because the arthroplasty techniques for the thumb base were predominantly developed in France and Belgium. Some of the earlier implants did have a high failure rate. Modern implants seem to work extremely well. But yeah, of course, any operation, including a hip replacement, a knee replacement, which are carried out by the hundreds of thousands in the world, can wear out. They can come loose. They can dislocate. The modern thumb-based joint replacements dislocate about 1 in 200 cases. I've only had it happen once, and that was in a young guy opening a car bonnet as a mechanic. We popped it back in for him, and it hasn't come out since. I've been doing these for 5 years. I haven't had to revise any. So the complication rate with modern implants, I think, is really quite low. And that's what the published data would suggest. So I'm surprised he's heard horror stories, but like anything, operations can have complications and they can be bad, but they're infrequent. The rate of infection, for example, in CMC joints is less than 1%.
Thank you. Before I go on to the next question, do you want to just put the slides forward again to the penultimate one? I think there's just a few details on the screen for people to read.
That one or the next one?
Next one. There we go. Thank you. Okay, so Stephen has a question, and he says, will exercise involving wrists and fingers aggravate carpal tunnel and trigger finger? And he also says he's type 1, I assume diabetes, for 40 plus years, but he's fit and exercises regularly. He's now 72, and he's had steroid injections. Must he resign himself to the issue continuing?
In terms of carpal tunnel?
Yes, I believe so.
So yes, I think either condition can be treated surgically, and surgical treatment for carpal tunnel and trigger finger works really well. There's a very low chance of problem, but it's not impossible, as the previous question suggested. But it's really very low, and the success rate for carpal tunnel is very high, even in patients that are diabetic. And the same with trigger finger. Steroid injections are less likely to work in trigger finger in diabetic patients, but they're not. But they still have a high success rate. But if they fail, surgery is just as successful. Things that will tend to make carpal tunnel symptoms worse, doesn't make the condition worse, but will make the symptoms worse, are things like holding an object for a prolonged period of time. For example, using a hammer extensively during the day, riding a bike for several hours can make the numbness and pins and needles worse. It doesn't tend to make the condition itself worse, but it'll make you more symptomatic. That's pretty much for sure.
Okay, thank you. We have another question from a different Stephen. He has Dogmatron in the right hand and has had one removed from a long finger. More recently, he now has it in his little finger, which has caused a ulnar deviation, which led to a dislocation of the first knuckle. Then in February 2025, it was removed and the second knuckle replaced as in an arthroplasty. Regrettably, this was not successful and resulted in little finger with as little as or no movements near the base, and the same deviation, which, as you described it, catches in other near items, causing pain and calamity. So quite a lot going on.
Can we do anything else about this? I think without really seeing the hand and examining it and really having a better understanding, I think that's quite a difficult thing to answer. It's clearly quite a difficult situation. You've had surgery for Dupuytren's disease and a knuckle replacement. So again, it depends on the type of knuckle replacement as to whether and how well that's aligned. Because for example, you can, like any joint replacement, the joint may not be aligned right, which is why you've got the problem. Or it could be that the Dupuytren's has come back or wasn't completely released at the time. So without seeing the hand, I think that's really very difficult to say. But it does sound like that's potentially fixable. But I wouldn't like to say so definitively without seeing it.
Yeah, that makes sense. Can injections be repeated for carpal tunnel?
Short version, yes. There are some patients that have had sort of 2-yearly injections for years and years and years. There's no such thing as about how many injections you can have and how close together they can be. But if you find that a steroid injection is helpful, reduces your symptoms significantly, having them very close together probably isn't a good idea, in that steroid injections everything has a downside. Steroid injections can cause a degree of weakness of the tissue. So if you have a lot of steroid injections put in the same place over a relatively short space of time, you can get issues such as tendon ruptures or ligament ruptures. That is possible. So if you have a steroid injection once every 18 months, year, and that holds your symptoms at bay and you're happy dealing with it like that, I think that's perfectly reasonable. Equally, if you get fed up with them, then it's very, very likely that a small operation under local anaesthetic would deal with the problem definitively.
Okay, thank you. Malcolm had a carpal tunnel operation in 2017, which was very successful. The classic thumb worst night numbness is coming back again. How successful is another operation on this hand likely to be?
So carpal tunnel syndrome can recur. It is not common, but it certainly can. And in this situation, I think nerve conduction studies are extremely useful, just to be sure about the diagnosis and also the severity of the nerve compression. But the answer to that is yes. I think assuming that the diagnosis is correct and this is a recurrence of the carpal tunnel syndrome, it's something that does work and does work well. It's not something that's performed on a very regular basis because recurrence is really quite rare. I probably do maybe one recurrence case a month, something like that, compared to, I don't know, maybe 20, 25 primary carpal tunnels. So it can be done again, and it is likely to be successful as long as the diagnosis is correct.
Thank you. Talking about being correct in the diagnosis, how accurate are conductive tests in diagnosing whether someone has cubital tunnel or carpal tunnel?
So any neurophysiology has what's called a false negative rate. So the test says the nerve is functioning fine, but the person has the condition. And that's the case in probably only about 5% of cases. And that's the same for carpal tunnel or cubital tunnel. So there is a small error rate with that test. Okay. The most important thing really is looking at the patient, listening to them, understanding their symptoms. The majority of people with a peripheral nerve compression will accurately describe their symptoms. You know, if it's their ulnar nerve, they'll tell you it's the small finger that's numb. They get shooting pains down the inside of the forearm into the little finger. And they begin to struggle with potentially how they place their fingers when using a keypad, for example. So the most important thing is listening to the patient. I think neurophysiology is helpful for cubital tunnel because the nerve can be compressed elsewhere. It can be compressed in what a anatomical structure called Guillon's canal, which sits next to the carpal tunnel. So the big ulnar nerve is actually compressed in the hand. And that's one of the reasons to get neurophysiology before operating on cubital tunnel syndrome, because there are a couple of places the nerve can be compressed, albeit the Guillon's canal compression is really quite rare. But yes, accurate. How accurate is it in basic terms? It's about 95%.
Thank you. Jennifer has a small lump on the side of her little finger at the base of the nail, causing a ladder-like deformation on that side of the nail. Should she do something about it?
So should she do something? I think that's really a personal decision. Almost certainly you have a thing called a mucus cyst, which is a variation of a ganglion. So there's a small pressurized bubble of fluid coming from the distal joint in the finger, which is sitting just where what's called the germinal matrix of the nail bed is. That puts pressure on it and causes the nail to grow with a deformity. It can be relatively easily sorted out with a small operation under local anaesthetic, which is highly likely to be successful. It has a very low complication rate and is something that people do have surgery for without question.
Thank you. I believe Maureen asked a question earlier. So she's asking about the angle of a contractor. For referrals previously, her doctor said it had to be more than 45% angle for a contractor to be then operated on. Is that measurement still used? She says,
So different funding bodies put restrictions in place. Historically, what was it called? Not the ICB, whatever it was before. People that pay the money for National Health Service operations put specific guidelines in place. Used to be 30 degrees, your local one may be 45 degrees. I think the more useful measure is it functionally a problem for you? And if it's functionally a problem for you and the angle's about 45 degrees, that seems a reasonable point at which to operate. It's not what I would call a severe contracture. Severe contractures, to my mind, and most hand surgeons' minds, are where the tips of the fingers are almost touching the palm of the hand. That is then very difficult. But a 45-degree contracture at the main knuckle, that should be relatively easy to correct.
thank you.
Even as a second operation or a third operation, if it's recurred.
Is there any point in having steroid injections for a thumb joint pain as it's only a temporary fix?
Again, I think that's a very personal situation. Steroid injections can be useful in taking pain away. They do not change the worn joint surface, so they don't solve the problem. They reduce inflammation, and some osteoarthritic joints do have a significant degree of associated inflammation. Trying to predict which ones those are, at the moment at least, is impossible. So some people will get a great response from a steroid injection and find they're pretty much symptom-free for 6, 8 months or even longer sometimes. So can it be useful? I think so. I think that does depend on your own personal mentality. If you want to delay surgery as long as possible, if you're young or just want to delay the surgery anyway, then they're a perfectly reasonable thing to do. Again, should you have it done more than once? I think each time you have a steroid injection into an arthritic joint, it becomes less and less successful because the inflammatory component to that joint pain has been resolved. So the steroid has less to do and the joint surface is arthritic, and that's what's causing the pain. So there can be a temporary fix, but again, is there any point in it? I think that's very much a personal decision, really.
Thank you. Anthony has tendon problems on both hands. One is at the base of the little finger, and the other he's had for about 15 years on the palm of the fourth finger. He doesn't actually ask a question after this. What would you advise he does?
It does depend on what the tendon problems are. If they're trigger finger, for example, they can easily be treated. If you have what's called a tendonitis, again, that's something that's open to treatment. I'm not sure what else to say. If he's happy to be more specific, I can try and be more specific.
I guess the best consultation is probably a good idea to discuss more detail. And then we just have one last question, which is surgery and general anaesthetic necessary for Dupuytren's conditions, and would you advise it for an 82-year-old?
So I think that comes down to a few things. Depends how fit, active, what you want to do with your hand, all come into this. It also depends on how bad the contracture is and where that tissue is. If the tissue is quite thin and in the palm, the needle procedure that I mentioned towards the start of the talk is eminently usable and gives great results. More significant surgery can be done with what's called an axillary block. So the arm is made numb and you can carry out really very extensive surgery using that technique. So if you're concerned about having a general anesthetic and have quite significant contractures, but otherwise fit and healthy and it's interfering with your hand use, then that extensive surgery can be carried out with what's called an axillary block, where the nerves to the arm are made numb and you can't feel your hand at all, and we can use a tourniquet, but you don't need to go to sleep, and that can work very well. Or if you, as I say, if the contracture is not as bad, a needle fasciotomy works very nicely.
Thanks. We do actually have a couple more questions. Jeff had carpal tunnel release operation in his right hand some years ago. More recently, he's had Dupuytren's contraction operated on the same hand, which seems to cause some carpal tunnel symptoms. Is it likely that the symptoms resolve over time?
So one of the things that can happen, as I said before, you can get a recurrence of carpal tunnel syndrome. and people can get post-operative carpal tunnel syndrome in that the swelling caused by the Dupuytren's surgery causes more general swelling in the hand, and that fluid puts pressure around the nerve. That should resolve relatively rapidly after the surgery. If, for example, that's still there at 3 to 4 months, I think that's likely to be a proper recurrence of the carpal tunnel syndrome, and probably should get checked out with a view to potentially doing the carpal tunnel again. So it can be caused by the secondary surgery for the Dupuytren's, but that, again, that's difficult to know without looking at timeframes.
Thank you. David says the middle finger of his right hand has the trigger finger problem, which is fairly mild, but he's recently noticed that the upper finger is bending to the left side. Is that a different problem?
Yes, probably. Trigger finger, if it's causing the finger to stick, will cause the finger to stick towards the palm and only pulls the fingers down into flexion, so towards the middle part of the palm. If the finger's being pushed sideways away from the rest of the hand, that's likely to be Dupuytren's disease. But again, without seeing the hand, it's difficult to be absolutely sure. But that would be my best guess as to that.
Thank you. And someone says they had a carpal tunnel operation December 23, which went very well. Unfortunately, they now have developed trigger finger in their ring finger. It becomes very locked at times. Do you think locked at times? Do you think surgery be necessary?
So I would definitely try a steroid injection first. That is successful in the overwhelming majority. So unless you've already had a steroid injection, I would definitely recommend a steroid injection. It's 90% chance that will fix the situation. So surgery is not absolutely necessary, no.
Great, thank you. So thank you again for all the questions and for being part of this evening's session. If we haven't covered your question and you have provided your name, we'll be able to follow up with you via email. If you could just move on to the final slide. Great. So as a thank you for attending, we're pleased to offer a 50% of the value of your consultation for a limited time. That's for 7 days. A call back from your dedicated private patient advisor, an email with a recording of this session, treatment information and loyalty reward points for joining the session, and updates on future events and health news. So we'd really appreciate it if you could take a moment to complete a short survey at the end of this session. It will pop up, as this helps us to improve and tailor future webinars to your needs. If you'd like to speak to someone or book a consultation, our private patient team are available until 8 p.m. this evening. They're also available from 8 a.m. to 6 p.m. Monday to Friday. You'll find the contact number on your screen to call. We also have upcoming webinars on a range of topics, including arthrosamid for knee pain, which is an injection for knee pain, and varicose vein treatment. You can sign up to these via our website. So on behalf of Mr. Smith and all of us here at Bendon Hospital, I'd like to say thank you once again for joining us, and we hope to hear from you soon. So take care and goodbye. Thank you.
Good night.